Dr. Helen Kenealy is a dual-trained geriatrician and general physician with over 20 years' experience in both public and private sectors. She is currently Chief Clinical and Risk Officer at MetLife Care and will be presenting on evaluation of the interRAI DIVERT assessment tool for predicting unplanned admissions and identifying opportunities for preventative interventions.
Perfect. Okay. Thank you so much. Thanks for having me. As Joanna said, I am a geriatrician and general physician. Currently, I work at MetLife Care as a Chief Clinical and Risk Officer. Today, I'm presenting research that was undertaken on the interRAI DIVERT scale while I was at Eastern Counties Manukau. And I want to present to you how DIVERT performs in the New Zealand population and what it might tell us about opportunities for prevention of unplanned hospital admission and earlier community-based intervention, which was what I would have done had I not moved jobs. I want to really acknowledge my co-researchers and co-authors, Dr. Ghassan Al-Aranji, Dr. Heather Estelle, and Dr. Tim Kenealy. And I'm pleased to note that this paper has been accepted for publication in the NZMJ later this month. So by way of introduction, we all know that older adults represent a significant proportion of emergency department presentations. The best data I could find was actually Australian data most recently from October 2025 that showed around 25% of all ED admissions are for people aged 65 or over. Now, clinically, we all know that older adults, they often present with undifferentiated symptoms, complex comorbidities, overlapping syndromes such as falls, infection, delirium, functional decline. And we also know that there has been a shift internationally as well as in New Zealand to focus not just on ED management, but to ask ourselves, how can we prevent people coming to ED and having unplanned hospital admissions? How can we identify these people earlier and have some better interventions in the community? And I think that's where the interRAI DIVERT scale comes in, and I think that this is a big opportunity for our public health system. So DIVERT stands for the detection of indicators and vulnerabilities for emergency room trips, right? Hence the acronym. And it comes from the interRAI Home and Community Care Assessment, widely used in New Zealand. What is it in a bit more detail? Well, it's an empirically constructed risk scale designed to predict the risk of unplanned ED visits, specifically for people currently at home or in the community. It gives you a score 1, 2, 3, 4, 5, 6. 1's the lowest risk, 6 is the highest. It's got 19 distinct outputs. The scale is driven by determinants such as cardiorespiratory symptoms, cardiac conditions, mood, functional decline, geriatric syndromes. It was originally derived in Canadian populations, because we know that's where interRAI comes from, and designed in their setting for private home dwelling and community care populations. So not intended for use within where I currently work, which is in aged residential care. And it's not just another frailty scale. It doesn't really overlap strongly with the other interRAI scales that focus on physical and cognitive decline. It's specifically tailored for this group of people who end up in ED. So just to give you a little bit more information about what it looks at, you can see the list there, and obviously this is all publicly available information. It looks at things like past hospital and ED use, decline of ADLs, are they falling frequently, and other factors such as catheter use, so things that might complicate their care or aspects that may make them more at risk for these unplanned admissions. So it's a multi-domain risk algorithm. It's grounded in routinely collected clinical assessment data. And I've got the schematic here for those of you that like to see the background workings of interRAI, right? So that you can see just how complicated it is in the background to get to your scores of 1 to 6. So there it goes. So this shows you that, as I said, the higher score, this is what you've got to remember, 6, the more likely an individual is to have that unplanned presentation to ED or hospital. So how should we be using it? It's not just about labelling someone as high risk, it's about segmenting risk into meaningful clinical subgroups and ensuring that we then can put some resource intensity of intervention to match that risk level. Intervention should be adapted to the subgroup, they should be proportionate to risk, they should be aligned with chronic disease management guidelines and supported by local clinical judgment. So the logic is that if you can identify these drivers of what's putting people into ED, you could intervene earlier. Now, I'm not aware of anyone in New Zealand doing this. Previously, and the way I found out about it is that they were looking to do this at Nelson Marlborough. To my knowledge, they're not. And as I said, I was on the verge of trying to do this in real life in Middlemore when I moved. So the first thing that we did was we sought to validate DIVERT. We've actually done this twice because we started this pre-COVID and then we re-validated it post-COVID. So I'm just presenting the post-COVID data today. So we wanted to see and make sure, obviously before we went to any funders or anyone within our department to ask for more resource, that indeed DIVERT was validated in our population. And then we wanted to see, well, is there a window for prevention? Is there a window for action where we could get in there? And we wanted to start to inform what would that intervention look like in the real world. So as I said, this study happened during the COVID pandemic. Large metropolitan hospital, Middlemore, well-established community geriatric service, which is where I was working at the time, and we still currently have about 1 FTE geriatrician there with 5 to 6 full-time equivalent community nurses, which is why I thought we'd be well-placed if there was an intervention window to jump in there and act. So this was a retrospective cohort study. We're talking about a population catchment of around 500,000 people. This study focuses on the work that we did from May 2021 to April 2022. We looked at over 2,000 sets of data. Just so you know in the room, obviously from a funding point of view, people who are age 65 plus technically are what we call older adults in this country. But at Middlemore, we've always, as long as I've ever worked there, we've always taken the age down to 55 for Māori and Pacifica. So that is what we did for this study, okay? And that helps us to make sure that we embed some ethnic equity into our assessments. So for people who identified as Māori or Pacifica in the interRAI, we took them in from 55. Our primary outcome was hospital ED presentations within 90 days of the interRAI HCA assessment, and we focused on the DIVERT scores that were high, so 5 and 6. So we wanted to know, if you had a DIVERT 5 and 6, if you're admitted, why? What's driving that admission? We had 2 investigators independently review the admission and discharge summaries for anyone who had a DIVERT score of 5 or 6 prior to their admission. We recorded both the primary and secondary diagnoses, acknowledging that, of course, older people tend to have more than one reason to come into hospital. And we had predefined categories based on the DIVERT components and clinical experience. So you can see a very long list there, things like infection, cardiac injuries, falls, pain, and so on. Our inter-rater reliability was 71%. For anything that was not agreed upon, we went through a robust process of adjudication consensus to achieve robust final categorisation. So in terms of our methodology, we were really disappointed that we initially planned to use the Charlson Comorbidity Index and we simply were not able to. We were obviously doing this in COVID. We lost all of our statisticians. They all changed over. We had all those lovely issues that you have when you were trying to do research in the real world while holding down full-time jobs. And believe it or not, we could not get reliably the dementia and delirium coding to come through. And of course, that's obviously a key component of the Charlson Comorbidity Score. So one of the limitations of our study is that we essentially had to sort of make up our own, which I know it's not ideal, comorbidity index. So we used a simplified score from 0 to 10. Each condition counted as 1 and included all the major chronic conditions from a Charlson Comorbidity Score, so COPD, diabetes, CKD, and the like. All of the data went into REDCap. That's what Middlemore uses. And we analysed the data using RStudio, Open, Epi, and Stouter. And statistically, we used Cox regression for associations and Kaplan-Meier plots for the time to admissions. So getting on to the juicy bits, I can tell you that we're validated twice, but this is the second validation, that DIVERT does indeed hold up in the county's Manukau population. So it does indeed predict admission. It was clearly statistically significant as you went through the DIVERT score to the rates of admission. So then you want to think about, well, who's getting admitted? So here, as I say, we just dived into those who were getting those scores of 5 to 6, right? We didn't really do much analysis on the 1 to 4s. So that gets us down to 354 patients. The strongest predictor of admission was clearly the comorbidity score, which was really interesting. So you can see the hazard ratio there was 1.51, which was highly statistically significant. Of interest, there were actually a number of factors that were not significant. We did have statisticians do all the power calculations and everything behind the scenes, which is how we got to all these magic numbers as to how many people to include. But unfortunately, we did not find any statistical significance with age, gender, ethnicity, or deprivation quintile, which is also something that we went back and did because we were surprised not to find differences in those main demographics. So in our high-risk cohort, the main predictor driving that diversion admission was clinical complexity. Now let's look at the time to admission. Is there a window for me to jump in there and intervene? Well, yes, I think there is. This gives us the practical insight. 15% of people are admitted within 72 hours. That would be a tight window. Although in the Franklin region, we do have a rapid response team, but I think that would be a push. But 42% are admitted within 14 days. That's a pretty good window. 20% admitted within 20 days. So there is a window there. So while some of them happen extremely quickly and prevention, I agree, would be limited, I think that for nearly half there is a window in which intervention may be feasible and therefore impactful. So if you look at why are they admitted, looking for some clinically meaningful gutsy information here, well, it was quite interesting because nearly 20% it was infections, pneumonia, UTI, and of course COVID coming up. Another 20% fell into our other box, which was a very diverse range of conditions. But you can see 12% decompensated heart failure, cardiac issues, 8% falls without injuries, 8% unmanaged pain, acute surgical problems, potentially not quite so preventable, but 8%, and respiratory issues, so non-infected respiratory issues were 7%. And I think the other thing to bear in mind here is that these are not obscure diagnoses. This is bread and butter stuff for GP and community teams, right? I would argue that a lot of this is preventable, it is manageable, and it is modifiable in the community. If you look down through here, this is just giving you more breakdown around that primary and secondary diagnosis. As you can see, a bit more detail towards the bottom. Yeah, you can see how they span across the primary and secondary diagnoses. The mortality data is really striking. So in patients with a DIVERT score of 5 to 6, there's a really stark contrast between those who were admitted and those who were not. If you had a DIVERT score of 5 to 6 and you were admitted, 38% were dead in 30 days. If you had a DIVERT score 5 to 6 and you were admitted, you had a chance of being 57% were dead at 90 days. That's pretty impressive. And actually, none who were not admitted died. So we just have to be careful here. I'm not suggesting that getting admitted to hospital causes mortality. So you really got to think about these numbers quite carefully. What it shows you is that you have a DIVERT 5 to 6, you're sick. And if you end up in hospital, you're really sick, right? So admission is a marker of acute deterioration and high short-term mortality risk. And again, from a clinical governance point of view, what that tells me is we need to escalate earlier. We need to be doing earlier care planning. And where's our advanced care plans? Here's our time to intervene there, isn't it? Let alone EPOAs and all those other things that as geriatricians we like to think about. So what does this mean in practice? So I think there's a window for intervention. I think it's real. I think it's an achievable time frame. What are we targeting? Acute infection management, chronic disease management. You could see respiratory and cardiac. They came up as the most common ones. Falls prevention programs, pain management, advanced care planning, enhanced social support. So where do we need to pay attention? I mean, this we kind of know, but it's high comorbidity groups. And despite the fact that there was no proven difference between ethnicity groups, of course, we would always look to see where our interventions can be specific for Māori and Pacific people. Number of study limitations, and we do need to acknowledge those. This is an observational, retrospective study. I explained the coding limitations, which we, really battered around for a good few months on, and we just could not overcome them, which was really disappointing. We did lack data on immediate interventions post-assessment. We didn't sort of specifically put a frailty measure in here, and our comorbidity index was simplified, as I said. But look, I think that currently DIVERT score, to my knowledge, isn't really being used anywhere. I think it's a huge missed opportunity. I think we validated it. We could see that comorbidity scores were the strongest predictor. Many admissions are due to conditions with intervention potential. And I do believe that there is a window where we could do so. So I had some ideas about the next steps, about targeted intervention programs, thinking about how we could evaluate outcomes and improve advanced care planning. So I guess my challenge is to someone in the system to take that up, because I believe that early intervention and early identification could reduce hospital admissions if you use the DIVERT scale. So there you go.
Thanks. Round of applause for Helen. Thanks. Thank you for a fantastic presentation. I think it's really important to show, the importance of those inbuilt algorithms and scales, and also that in this case it stood up in the New Zealand context. So and then thinking about what does that mean in practice. So a fantastic presentation to show the importance to individuals from these assessments, but using that data at a research level, like population level. So thank you. We do have a few minutes for questions. Simone, I'll come to you. And again, online, feel free to post your questions in the chat.
I'm presenting next, but I want to talk about this more. Nelson Mulberry, you're quite right, did look at this when I did this in 2020. And
what sparked my interest. There you go. Yep.
And as Gary pointed out, we all know what happened. Yes. I presented this at the 2020 Knowledge Exchange, and it kind of didn't really continue post-COVID. But what we found, so the idea was that we would look at the DIVERT scale, and we would do an intervention looking at ACPs, doing a medication review, making sure they've seen their GP, making sure they've seen an allied health professional around their falls and equipment and all that sort of stuff. One of the things we found out, so I was interested to see your mortality scale. One of the things we found out is we just didn't get there quick enough. So unlike your scale, even the ones that weren't admitted, the mortality rate was really high. So we were just in the process of dropping it down to like the fours before we intervened. But I guess my real comment is going back to what I mentioned earlier about the outcomes for the home and community support. Is let's get the DIVERT in there and see if we can use this as an intervention. Then I think we can have a significant impact. But I'd like to see it in the new home and community support model.
So we, so just for my context, and interestingly enough, Dr. Heather Estelle now works at Nelson Hospital. If you want to hit her up, are you still at Nelson?
No, I'm not anymore.
Well, there you go. So, just of note, all of us authors no longer work at counties, which is why it didn't go anywhere. So because we had such a well-established, well-functioning community geriatric team, and we did triage at least once a day, my intervention plan, which we never got off the ground for resourcing issues, essentially, because we were already completely swamped, was that essentially anyone who had a interRAI HCA with a DIVERT score of 5 to 6 would be triaged directly to our team, and that they would be flagged as urgent. And that's why I was confident in our context, because of the scope of our team and how quick we are. NESC in our area was also extraordinary. I was quite confident that 14 days actually was enough, but I totally respect that would not be true in some other areas. And I had a list longer, but sort of similar to what you're saying, and to sort of work through what would we do. And of course, at counties, we had access to heart failure nurses and respiratory nurses and all that jazz. So, I do acknowledge that we had a wider base of supports that we could draw on, so it wouldn't all fall to our team. So that was my grand plan.
Thanks, Helen. Bridget, one last quick question.
Actually, it's just more a comment, really. Fabulous presentation. I think dementia is underreported anyway, and that's because assessors don't like to write a diagnosis that hasn't been made by the medical profession. And the medical profession aren't that great at diagnosing dementia and having it in records. So
Yes, correct.
that's your,
Well,
apart from very special people. So that's
yeah, you're right.
And the other comment I made, if someone said, look, we've found this new blood test, and if we just give this blood test, and it's going to cost a small amount of money,
Yes.
and you avoid ED.
Yes.
Intro assessments are being done anyway.
I know.
There is no extra cost.
Yep.
So it's about communication, really, isn't it?
Yeah.
And I'm not telling you, I just felt the need to share.
No, absolutely. Yeah, I mean, there's a lot of cognitive impairment in the notes. And yeah, that in and of itself, I guess when you do these sorts of research projects, you discover all sorts of issues, one of many being far out. How do we get any decent data around what's happening with dementia and delirium in our hospital, and where I was working at the time, system, when we clearly exposed a very large gap in the coding?
And Helen, thank you. I just wondered too that with the frequency of inter-RAI assessments, home care assessments, and you were looking at 5 and 6s, was there an obvious progression from the 1s, 2s and 3s and 4s that you would have noted that
Yes.
last year it might have been a 3 and now it's a 5 or 6? Not so much with the delirium, but
so we didn't do that one,
No.
Scully, actually, but it would have been quite interesting. And I mean, you can see the numbers. I mean, over a year there were 354. So in terms of triage, I estimated it would be maybe 10 to 12 a week, but it's all those flow-on effects of the increased workload for everyone. And I couldn't get agreement that we would have some funding to get some extra FTE to address that issue, because no one, particularly post-COVID, was prepared to take up yet more unpaid work. So it would require some funding and some resource.
Thanks very much, Helen.